Okay, well, it's 12 noon. So for those of you who are on the line, I want to introduce myself. I'm Judy Talley. I'm the program director for PMD Alliance. Margie Gray is on. There's Margie. She's our events coordinator. And Sarah Jones will be joining us. If you've got video, you can see she's speaking at one of our events down Tucson right now, but she's going to jump on and join us as soon as she gets everything rolling there. So we are looking forward to this. For those of you who are new to us, welcome to Lunch with Docs. This is a monthly event we have online. We all get together in our respective places at home or at work, and it's very informal. We have a physician speaking about usually topics related to Parkinson's or other movement disorders. And hi. And we do this in their office. Dr. DeOcampo just joined us, and they're seeing patients up until it's time for lunch. We ask them if they'll spend the lunch hour with us and talk. So that's what we're going to do today. Dr. Ocampo, it's good to have you. And it looks to me like you might be muted.
Enter your participant ID followed by pound.
Oh, I hear it.
Should I use the phone or should I just, can you hear me clearly?
We can hear you right now. You can use your computer speaker.
Okay, that's fine.
Great. Well, it's great to have you. Thanks so much for joining us. Our monthly talks with doctors are so wonderful because, of course, they're live, real questions. People get a chance to really focus in on particular topics with experts like yourself. And thank you so much for doing this.
You're welcome. It's a pleasure.
Oh, we're glad to have you. And let me just introduce you. You are Dr. Jose Joel DeOcampo, an MD that's board certified by the American Board of Psychiatry and Neurology and the American Academy of Sleep Medicine as well. And your practice includes sleep disorders for people with neuromuscular disorders, movement disorders, as well as various subspecialty areas, from checkups to treatments. So you've been in practice since 2001 and board certified neurology and sleep medicine. And what's wonderful for us is that you possess a special understanding of the profound issues facing people with PD and other movement disorders, as well as their care partners. So thank you so much for doing this for us. And what we like to do is, if you'd like to make just some opening remarks to kind of get the conversation rolling, and then people can either just ask questions directly of you, or if you all are familiar with Zoom, there's a chat feature as well that you can use. If you go to the bottom of your screen, it says chat, and you can actually, what we'll do is we'll mute the people while you're talking, and then they can write in their questions on the chat feature for now. That way we won't be jumping over each other trying to talk. So Dr. DeOcampo, thank you so much.
Okay, so thank you. Thank you for inviting me. I really appreciate it, and I'm glad to be here, actually. I am a board certified general neurologist as well as a sleep specialist. I do work closely with the movement disorder specialists in the area as well. And I guess the topic for today really related movement disorders. It's more of a sleep-related movement disorders. Obviously, the more well-known movement disorder is Parkinson's disease, and a lot of movement disorders are associated with sleep disturbances. Parkinson's disease patients are known to have restless leg syndrome and periodic limb movement disorder. And we'll talk about that in a little bit as well. Some of them can have sleep-related leg cramping or even teeth grinding. We call that bruxism. In some cases, some Parkinson's disease patients also have what's called as acting out behavior, wherein they act out their dreams And this can occur even 10 years before Parkinson's disease is diagnosed. And that's called a rapid eye movement behavior disorder, or REM behavior disorder. So we'll get into that as well. Yes.
Sorry to interrupt you. We are projecting you to a room of 100 people as well. Yeah, you didn't know that. I'd show you, but I don't want to disconnect the internet.
Okay.
If you can talk just as loudly as you can, because they go all the way back and they're listening to you.
Oh, okay. Are you hearing me now, though? Are you hearing me well?
We're hearing you pretty well. You could even talk louder, though.
Because I can also
But we can hear you pretty well.
Yeah, because I can also call in on the phone.
Okay.
If that might make it clear. Let me see if I can get that going here.
I might make it a little. That's great. Okay, so he's going to call in, just then it'll be a little here. For those of you that are here, now you see what happens in the background. You don't usually get to see the behind the scenes. This is what happens behind the scenes. Yes, this is being watched by people all across the United States right now.
Oh.
Yeah. Mm-hmm. Yep. Oh, wonderful. Yeah, it's wonderful. We have, and that way people who live remotely or don't have access to movement disorder physician, or if you're on vacation, you can log on and you can still listen. All right.
Yeah. Is that better? I don't know if it's better. Can you hear me?
I think it is.
Okay. I was saying that we were talking about Parkinson's disease and type of movement disorders or sleep disorders can be associated with Parkinson's disease. And far and away, the most common form that I can think about is something called Restless Leg Syndrome with periodic limb movement disorder. So Restless Leg Syndrome is a syndrome wherein you have an uncomfortable feeling in the legs at bedtime or at rest, and it can be relieved by movement. It is usually worse at night. And in a lot of cases, it can be associated with rhythmic twitching of the arms or legs or both. And when it's accompanied by the twitching, it's called a periodic limb movement disorder. Another thing that is associated with Parkinson's disease is something called a rapid eye movement behavior disorder, or REM behavior disorder. The REM behavior disorder can actually precede the diagnosis of Parkinson's disease by almost 10 years. So you could have symptoms of REM behavior disorder and not have any symptoms of Parkinson's disease yet. And REM behavior disorder basically is a disorder when people start acting out their dreams. So there's going to be flailing of the extremities, shouting. People might feel like someone is running after them or they're fighting against someone else in their dreams. And it's usually the bed partner that brings it to attention because it can be potentially harmful to the partner. I've had cases where the partner had actually inadvertently, accidentally, obviously, been hit in the face or in the body when the person with the REM behavior disorder is acting out. It can usually be diagnosed and treated in a sleep center. Now, you can also get nocturnal leg cramping or sleep-related leg cramping episodes, and that is also something that neurologists can treat in the office. They say that almost as much as 60 to 80% of Parkinson's disease patients have a sleep disorder, and that a lot of them can easily be treated in a sleep center. So I work closely with a lot of the movement disorder specialists in the area, including specialists at the Muhammad Ali Parkinson's Disease Center. And some of them also have been working at the Mayo Clinic. So we've been trying to figure out a way to definitely make the lives of Parkinson's disease patients better by helping them get a good night's rest. So that's like a quick overview of some of the movement disorders that you'll be able to see in Parkinson's disease. I think rather than go into a long discussion and lecture, I'd rather take questions from those who may be interested in asking about these things. So maybe we'll open up to the audience, whoever has questions.
Okay.
Okay, can you hear me, Dr. DeOcampo?
Yes, I can hear you clearly.
Okay, so we have had a few questions that were submitted in advance to us, so I'm just going to ask you those. One is there anything that you can do? Is there any medication that is safe and good for someone to take with Parkinson's disease?
With regards to sleeping, you mean, or in what context? Is that in a context of insomnia, or is that in a context of restless leg syndrome or REM behavior disorder of that sort?
So I think that's a really good question because the question wasn't specific. So I say D, all of the above.
Okay, so I mean, in patients with restless leg syndrome, the two most common medicines that are used are medicines that also affect the dopamine system, which is the main problem with Parkinson's disease. So in patients who have, for example, restless leg syndrome, the theory is that there is a problem with the dopamine transporter system. And so medicines that affect dopamine like ropinirole or pramipexole or Mirapex have been first-line treatment for restless leg syndrome. And these two medicines actually also help with treating the periodic limb movement disorder. We've also used carbidopa-levodopa as second-line treatment for restless leg syndrome. But the first-line treatment is primarily Mirapex or pramipexole, Requip, or ropinirole.
Okay, another question was related to melatonin. Somebody was told that melatonin is actually pretty effective and a safe thing for people with Parkinson's.
Yes, I agree with that. In fact, I mentioned to you again the RBD or the REM behavior disorder. In REM behavior disorder, when people act out their dreams, there are two basic starting medicines that we use to treat it. The first one is melatonin to treat the REM behavior disorder. And as I mentioned, REM behavior disorder can occur even 10 years before Parkinson's disease is diagnosed. So I would think that that would be safe for Parkinson's disease. And the other medicine is called a benzodiazepine that's used to calm down the abnormal behavior. But melatonin is safe for Parkinson's disease patients. Just on one thing on melatonin, the over-the-counter melatonin that you can get in stores, the levels will peak within an hour, and then it will drop just as quickly. So melatonin, theoretically in the sleep disorder world, has been used for sleep onset insomnia, meaning patients who have difficulty falling asleep. But if you have sleep maintenance insomnia, then that means you have difficulty staying asleep. So again, there are two types of insomnia: sleep onset and sleep maintenance, meaning sleep onset insomnia, you have difficulty falling asleep. Sleep maintenance insomnia, you have difficulty staying asleep. If you use the regular over-the-counter melatonin, it is effective for sleep onset insomnia because the levels will peak in an hour and then it will also drop. But there are newer formulations of extended release melatonin that will stay up in your system for 7 hours. One of this just came out. It's actually called REM Fresh, R-E-M Fresh, F-R-E-S-H. REM Fresh is an extended release melatonin that lasts for 7 hours before the levels drop. And as you know, high levels of melatonin help you sleep and stay asleep. So if you're going to take melatonin for Parkinson's disease or REM behavior disorder, I probably would recommend the long-acting formulation. The dosage will probably be anywhere from 4 to 6 milligrams for Parkinson's disease patients.
That's fantastic. I didn't know there was such a thing as a long-acting, slow-release melatonin. Is that prescription or is that also over the counter?
It's over the counter. I think the manufacturers just came out with REM Fresh, and it's actually, if you look at Amazon, for sure you'll find it. Not a plug for Amazon there, buddy.
But it's easy. Here, and I'll put a plug in. If you go order from Amazon, put in that you want to have them donate to Parkinson Movement Disorder Alliance, FYI.
There you go.
But you said the dose is 4 to 6 milligrams?
Yes.
Okay, that's great. I did not know they had that. Does everyone with REM behavior disorder develop PD?
No, it doesn't necessarily follow, but to be honest, when you have REM behavior disorder, it tends to be a degenerative condition. So I would say the number is pretty high, though, that there might be a higher incidence of Parkinson's disease. I would say probably even as high as almost 80% in some studies. But I think in my personal experience, it's lower than that.
How about with REM behavior disorder, in the beginning, maybe the dreams aren't quite as violent, or maybe there's not as much movement. Does that increase as the disease progresses?
Not necessarily. The movements can stay the same. They can be violent, and that's why most of the time that's when they end up in the sleep disorder center, because you need to help the partners, and you need to prevent the partners from being injured.
Right, absolutely. When people come to like a sleep disorder center or like your center, do you always do a sleep study, or is that something that's done frequently with people with Parkinson's?
If the patient with Parkinson's has insomnia, meaning difficulty, again, falling asleep or staying asleep, then there's no need to do a sleep study. Mostly because, if someone says they have insomnia, there's really no reason to document the insomnia. If there's a question of whether there might be sleep apnea, for example, then yes, a sleep study would be the only way to diagnose this. Now, in the sleep center, what happens is that we used to have the Parkinson's disease patients come to the lab all the time because we wanted to diagnose the periodic limb movements that occur when the Parkinson's disease patients are sleeping. But if the evaluation is purely because they have potential sleep apnea, then nowadays you can actually do a home sleep test. And so the Parkinson's disease patients don't have to leave their homes, because that's the main problem with Parkinson's disease patients. Sometimes it's so hard to get them out of the house and leave them in a lab and then pick them up the next morning. And it's just harder for a movement disorder patient. So nowadays, if it's a simple sleep apnea evaluation, meaning they snore, they're sleepy all the time, they have potential apneas or stoppage of breathing, then the Parkinson's disease patients can also have a home sleep study in the convenience of their home. So I just wanted to throw that out there for neurological patients.
Okay, great. When someone is having a REM dream and acting it out, should I try to wake them right away?
I would not wake them up. I mean, patients who are woken up in the middle of the dream may suddenly act out the dream on you without really knowing it. And if the dream was violent, then you might be the beneficiary of a swing, a punch, a kick, and I would probably not do that.
Oh, that's so.
And definitely, just as an addition, definitely do not tie down a patient with REM behavior disorder, because they might hurt themselves in the process when they start acting out the dreams.
Okay, and why do people with Parkinson's feel the need to urinate more during the night than during the day?
I think it has to do also with the mechanics of not just the movement in the whole body, but even the movement and the muscles of the bladder, of the urinary tract. Everything seems to not work properly. So the question is there does the bladder not empty as well? Are you not contracting the bladder the way it should? Is it a slower movement when it contracts? So it is not a full, they don't fully get rid of the contents of the bladder. So one thing that can cause frequent urination at night as well is the untreated sleep apnea. So I just wanted to throw that out. Just because you have Parkinson's disease doesn't mean that you cannot have sleep apnea. So untreated sleep apnea also causes frequent urination at night. So if the Parkinson's disease patient comes to the sleep clinic and says, I have frequent urination at night, or we call that nocturia, then sometimes that will also prompt a sleep study.
Oh, okay, that's good to know. Oh, it just dropped out of my head here, but let me see. Related to that, are there any things that people with Parkinson's can do to reduce needing to go to the bathroom during the night?
Yeah, the easiest way is cutting down on fluid intake within 3 hours of bedtime. So you want to make sure that you're not on any medication, of course, like a water pill or a diuretic that you're taking too close to bedtime. So a lot of the blood pressure medicines will have a combination of a blood pressure pill with a diuretic like hydrochlorothiazide. Some people will take Lasix and all that stuff for other problems. And you want to make sure that that's not an issue. I usually tell patients that within 3 hours of bedtime is to take sips of water, not gulps of water. So there are some people who are always scared that their blood pressure might drop because they're dehydrated and all that stuff. And that leads to increased fluid intake closer to bedtime just because they don't want to be dehydrated at all. But then that just simply leads to disrupted sleep.
Okay. What are your thoughts about naps for people with Parkinson's?
Naps are healthy, except if it starts to impede on your ability to sleep at night. So in patients who like to take short naps during the day, that's fine. I mean, Parkinson's disease, patients tend to be a little bit more sleepy anyway. But if it's causing you to have insomnia at night, then it would be better to avoid the naps.
Okay. You know, I think that one of the things that is special, and one of the things I enjoyed when I met you, is there's sleep specialists out there, obviously, and there's obviously neurologists out there, but to have a person that has a specialty in both areas is really unique. And I just wonder if you can talk about that a little bit, because you obviously chose to go into both areas. And
Yes.
I think you probably do stuff in a different way.
Yes. I enjoy it. I mean, I am able to treat sleep disorders associated with a variety of general neurology. So sleep disorders are not isolated to Parkinson's disease patients. Patients with multiple sclerosis are always tired, and they always need some help with assistance of their fatigue. Patients with Alzheimer's, dementia, likewise, have sometimes a reversal of their sleep patterns where they're sleeping during the day and then they're awake the whole night at some point in the Alzheimer's dementia process. So these are things that neurologists like myself study and try to help with. One interesting feature is another disease called narcolepsy. Narcolepsy is a genetic tendency to be sleepy, and usually these people fall asleep anywhere. So these are people that really need help because it's a very potentially incapacitating disease. I think that the field of neurology and sleep are intertwined. For one thing, neurologists like to study brainwave patterns. And of course, when you sleep, we study brainwave patterns all the time. In patients with epilepsy or seizure disorders, can have seizures only when they're sleeping. And so that's when neurologists can really make a change in their lives.
Right. If someone was to, come see you for an evaluation, is it sort of like a neurology evaluation where it's maybe every few months, even if it meant a drive? I don't know, the times when I'm not sleeping long term, it would be worth a drive every few months to be able to get some help with that. Is it something that can be done if you don't live, in Phoenix or nearby?
Well, the nice thing about the field of sleep medicine that's coming up this year is that they've started telemedicine. So just like what we're doing now, we're going to be able to offer sleep specialists all over the nation will be able to offer consults that will be covered by your insurance plans, of course. You'll be able to do it like this, what we're doing right now. So you'll tell me what your problem is, and then there might be some way for me to tell you, can you like show me your tongue, open your eyes, look left, look right, and we can do the general examination via teleconference. So that's in the works right now. I think this year, towards the end of the year, you'll see that the American Academy of Sleep Medicine will be promoting that.
Oh, that's fantastic. We'll keep in touch with you about that. And when that is,
Yes.
ready to go, we will make sure to do an e-newsletter to let people know that that's available. That's fantastic.
Yes.
I'm glad to hear that. Okay, I've got a couple questions. Sorry, I got off on a little tangent there, but are there some changes in sleep simply due to aging?
Yes, I mean, unfortunately, as we get older, the natural progression of sleep as you get older is fragmentation of sleep. So it's not actually better sleep, but fragmented sleep. In addition, you'll notice that there is a slight change in your circadian rhythm. The circadian rhythm is a 24-hour rhythm. You're awake for 16 hours and you're asleep for 8 hours. But as you get older, that circadian rhythm shortens. It becomes a 23-hour rhythm. So people who get older tend to want to go to bed earlier, and then they'll tend to want to wake up earlier. And that's not necessarily abnormal, but like teenagers tend to have a longer circadian rhythm during their teenage life. So their rhythm is 25 hours. So teenagers like to go to bed late and wake up later, and that's not necessarily abnormal as well. So it's just that the changes in life produce that. With teenagers, as you hit 21, 22, that circadian rhythm then goes back to 24 hours. That's the normal process. So you tend to sleep normally at that point in time. There are some colleagues of mine that are larks. They have a 23-hour genetically shortened rhythm. So these are like my colleagues who are surgeons, neurosurgeons. They like to wake up at 5 o'clock in the morning. They'll be in the OR by 6 o'clock, so they'll be done with their surgery early. So they use that to their advantage. Then there are some people who have a long circadian rhythm, and they like to go to bed early in the morning and wake up late in the morning. And these are the shift workers, nurses, people who shift work a lot. So having a different circadian rhythm doesn't necessarily mean it's abnormal. But going back to the question for the elderly, it tends to shift to a shorter circadian rhythm and becomes more fragmented. And so a lot of the patients I also get in my clinic above the age of 65 tend to want they tend to want to get help for their sleep disorders as well. A lot of the prescriptions being given for sleeping pills nowadays are in patients 65 and older, actually.
Really? Now, a lot of those are, what are those called? The kind of medications, the sleep medications.
Yeah, I mean, they're called, the soporific medications, there's different classifications of them. Some of them are hypnotics though, like zolpidem and Lunesta and all that. Those are hypnotic medications. A little more difficult to use that when you're 65 and older because it increases the risk of falls when you wake up in the middle of the night. So you have to be very cautious when you take that.
yet another reason to see a honestly, to see a specialist who understands the neurological issues that you're dealing with too, I think, you know, with the stiffness and rigidity with Parkinson's.
Yes.
Why do the dreams of people with Parkinson's, why are they so violent and often bad dreams in general?
Yeah, I mean, hopefully we can get to that stage in our research where we can actually analyze the dreams. I mean, a lot of the literature nowadays on dream analysis are out there, and there's not much of a major scientific basis on the interpretations. But hopefully one day we'll be able to see what people are dreaming and actually truly figure out what's going on.
Do you think that some of the bad dreams, even if you don't have REM sleep disorder, that maybe some of the bad dreams is sort of REM sleep disorder, not as exacerbated?
It can be part of that spectrum. I mean, it doesn't necessarily mean you have to get REM behavior before Parkinson's disease. You can still develop REM behavior disorder after the diagnosis of Parkinson's disease. So, and you have to also remember there are certain medications that can sometimes trigger nightmares. One common one that I see in the clinic is actually a common medicine we use for dementia. It's called donepezil or Aricept. And one of the side effects of Aricept is actually nightmares. And so when that happens, sometimes we have to switch them out of that medication. So it's not just a change in the brain pattern. Sometimes you have to take into consideration the drug interactions that happen as you get older.
Okay. And how does lack of sleep affect cognition?
Well, sleep deprivation, I know sleep deprivation for sure can contribute to cognitive impairment.
Go ahead,
It's
sorry.
definitely one of the things. In fact, if you have sleep apnea and your oxygen levels are always dropping below 90% at night, that can also cause cognitive impairment. So any type of sleep deprivation can contribute to cognitive impairment for sure. I know personally from experience that if I only get 5 hours of sleep at night, the following day, it's really hard to function in the clinic. So getting at least 7 hours of sleep is really optimal for adults.
Okay. Oops, sorry. I've got the microphone here and then I rub it against anyway. Okay.
Do you want me to repeat that, or did everybody get that?
Did you guys get that? Or? We got it. Okay, we got it. What happens during sleep? What happens to the memory during sleep?
Theoretically, they say that most of memory consolidation occurs during REM sleep, rapid eye movement sleep. I know that memory consolidation probably happens also in non-REM sleep, but I think the theory nowadays is that most of memory consolidation occurs during rapid eye movement stage. So there's 4 stages of sleep. You have drowsiness or stage 1, stage 2, slow wave sleep, and then rapid eye movement sleep, which is supposed to be restful sleep. And that's when the memory consolidation is thought to occur.
Okay. Now, this would make you a magician if you could solve this one. But for care partners, do you have any recommendations for care partners who are also impacted by sleep challenges, just simply by, by the nature of having the disease also in a different way?
Yeah, I mean, the caregivers are also very important in the treatment of patients with neurologic disease, because really everything depends on the caregiver. There has to be an emphasis in the clinic of not just taking care of the patient, but also talking to the caregiver and letting them know you are an important integral part of this whole treatment process. The patients who have Parkinson's disease lean heavily on their caregivers, literally and figuratively at this point. And really that plays an important role. The caregivers might be suffering from what we call environmental insomnia, wherein it's the environment around them that's contributing to their sleep deprivation. They can't sleep because the sick person is snoring, or the sick person is twitching with their periodic limb movements in bed, or the sick person is acting out their dreams, and they can't get a good night's sleep. And if they leave that patient alone in bed, the patient might fall out, something might happen, and it's really a very important dynamic that needs to be taken into account.
Excellent. I want to just ask real quickly, because I haven't asked many people from the audience here. Does anybody have any particular questions? Yes. What do you think about clonazepam as a drug for REM sleep?
It's first-line treatment. When I mentioned earlier that benzodiazepines may be helpful for REM behavior disorder, the first-line drugs are actually clonazepam and melatonin.
Great. What would help you if someone was going to come see you? What would help you? Is keeping a sleep diary helpful? Symptoms? What kind of information do you need to help address and diagnose the issues?
Yes, a sleep diary is definitely helpful, especially if the complaint is daytime sleepiness. The most common cause of daytime sleepiness is insufficient sleep at night. So if you have a sleep diary, then that will help document that problem. Having a partner with you that will say, yes, he snores, yes, she stops breathing at night, yes, his legs twitch, that will all help separate what's going on. Now, for the acting out behavior, definitely the partner's the one that describes it. Sometimes the patients don't even know what they're doing. All they know is that they're waking up in the floor. And so the caregiver, the partner, is the one that provides really the crux of the whole clinical history.
Okay. How about dystonia? Obviously, since you're a neurologist, you deal with all different kinds of neurological challenges. How about dystonia as it relates to sleep?
Cervical dystonia is an abnormal muscle tone that affects the neck muscles. What happens is that the dystonia will tend to pull your neck or your head into one direction or another. So it's very difficult to sleep if that is happening during sleep. That is usually easily treated with Botox injections.
Okay. And that's the, pardon? With Botox injections. Yep. Okay, we have another question. Okay, so sure. Okay, two quick questions here. The first one is, I'm going to go backwards from what she just said, but her understanding was Medicare will only pay for a sleep study if it's done at a sleep center. Do you know if they're now covering it for the at-home sleep studies?
Yes, I know for a fact that they are covering for at-home sleep studies now.
That's fantastic. What a great thing. The other is she's found that with her husband, if she kind of props him up with pillows so that he sleeps on his side as opposed to his back, he sleeps a lot better. And she's curious if you have any thoughts about that in terms of positioning for sleeping better.
Yes, now I'm going to go, and to answer that, we're going to go with the field of sleep apnea for a second. Patients who sleep on their back are noted to snore louder and to have a increased number of apneas. Again, apneas are when you stop breathing at night. So it's always worse when you're sleeping on your back, and actually it's also worse when you hit REM sleep. But asking the patients with sleep apnea to avoid sleeping on their back diminishes the snoring and the potential apneas that occur. So in that way, they get more restful sleep.
Okay, so propping up is good. How about you know, positioning the head to be at an elevation?
It's the same principle, yes, the same principle. As long as you're not lying flat on your back, then you're less likely to have severe sleep apnea.
Okay. if someone has REM sleep disorder, what are the safety concerns, and how do you have that conversation with someone who may not know that they really are that potentially dangerous at night?
Right. I mean, I mentioned earlier not to tie them down for sure because they might potentially injure themselves worse. The concern there is whether they get to a point where they're actually at risk for falling off a window, second story window at home, or getting out of bed and opening the door and ending up going outside the house, like a sleepwalking behavior. So those are the ones that may be potentially injurious. In addition, the furniture around the bedroom should not have sharp corners in it. Hopefully there are no scissors around the bed. You know, you're not putting any kind of decorative knives on the walls or anything like that. Uh, Definitely, the patient with a REM behavior disorder should not have any potential access to a firearm. And all these are safety concerns that need to be addressed. The other is, are they going to be at risk for running into the wall when they get out of the bed? You know, and is that wall at a corner where they could potentially hit their face in or something like that? All these need to be taken into consideration.
Yeah, the rounded corners, actually, I hadn't thought of. Okay, we have another question. What about CPAP machines? Is that if you have apnea or just in general? Was that apnea? Does CPAP machines help with Parkinson's disease?
It'll help if they have sleep apnea only. Parkinson's disease patients don't really need to be on CPAP in general if they don't have sleep apnea. The nice thing about CPAP machines is that they're getting smaller and smaller and more portable. There's a CPAP machine that's as big as the palm of your hand that you can take on airline trips and travel. So I think that that is, you know, a convenient option there.
For somebody to see a physician, a sleep physician, and get a good sleep consult, that is something covered by Medicare, and do they, I'm assuming, and they don't have to have a referral, or do they?
I don't think so. I mean, there are so many insurance plans nowadays, it's making my head hurt, but I don't think in general a referral to a sleep specialist would be the same way as a referral to any specialist.
Okay. Any other questions here? Oh, I've got a question, okay. Oh, does having REM behavior sleep disorder, does that have, does that lead to or indicate a poorer prognosis for Parkinson's? Are those correlated?
It does not necessarily correlate with that, no.
That's good news. What did you say, what percentage did you say have REM sleep disorder?
You mean in the general population?
In Parkinson's.
Oh, in Parkinson's disease, in my experience, it's around 50% of patients who have REM behavior actually go on to have Parkinson's disease.
Okay.
So when you think about it, there's also a 50% chance that you're not going to develop Parkinson's disease.
Right. Okay, that's great. And I have another question back there I saw. Oh, okay. This is related to carbidopa levodopa. We might need to have Dr. Reed do this one, but it's related to tremors and 25-100 carbidopa levodopa and the impact on tremors.
Right. I mean, carbidopa levodopa will help with tremors. There are other medications we use in Parkinson's disease to help with tremors. It's not solely just with carbidopa levodopa. 25-100 is actually an average to low dose for carbidopa levodopa. In patients with moderate to advanced Parkinson's disease, we'll probably need a little higher dose than that. But it's not only that medication that we use for tremors. I can think of 3 or 4 other medications.
Okay. Are there any medications that are contraindicated for sleep medications for Parkinson's? You know what I mean?
Yes, no, I don't think there are. I mean, my only concern for sleep medicines are high doses of benzodiazepines like lorazepam or Xanax or Valium, because these medicines have been associated with a higher risk of falls in patients above the age of 65. So above the age of 65, as you mentioned, sometimes you end up going to the bathroom more frequently, especially in patients with Parkinson's disease. And if the doctor tends to prescribe benzodiazepines, then I'm concerned that there might be a higher risk of head injury or risk of falls with hematomas in the brain and all that stuff. So I would be very careful to prescribe benzodiazepines in 65 years old and above.
Okay. How about Ambien?
Ambien has been used. I would try to use a lower dose, maybe not go above 5 milligrams of zolpidem if you're needing to use that.
Okay. Do you find that the Ativan or Xanax have any kind of mood impact?
Well, definitely there's a calming effect for both of them. The higher risk, there's a higher risk of developing dependence though. There's a high risk of needing to take more of the dose to get the same effect when it comes to anxiety. And we call that phenomenon, it's called tolerance. So patients become tolerant of the medication, and then to control the anxiety, then they have to take a higher dose to have the same effect. And then it keeps on going, and then how does it stop? So that's the concern for that.
Right, okay. I've got another question back there. Okay, so I'm going to break his question into two because one of them we'll save for a little later this afternoon, and the other one is, does serotonin help Parkinson's, and does it help, I would ask too, does it help with sleep?
Definitely serotonin plays a big role with sleep. The use of serotonin and other neurotransmitters in the brain definitely affect the way people will sleep. Serotonin has been implicated in the REM pathway, the rapid eye movement pathway, so that's also very important. For Parkinson's disease, the main problem is more of dopamine though, not really serotonin. But I would imagine that Parkinson's disease patient, like any normal person, will need a correct serotonin level to be able to get rapid eye movement sleep.
Okay. Question about, there's a question about Aleve PM or one of those kind of, anti-inflammatory medications to help sleep. Your thoughts about that?
I think they're good for short-term use. The problem with the PM component is that it has Benadryl. And it has been shown that chronic long-term intake of Benadryl contributes to a dementia-like picture in the elderly. So the chronic use of a PM medicine or something that has a lot of Benadryl, you have to be careful, especially when someone comes into the clinic and says, I have difficulty concentrating, I have memory impairment, and then you see that they've been taking Benadryl for 10 years. So at that point, you really need to be able to curtail the use of the Benadryl component, the antihistamine component.
Wow, okay. How about alcohol and sleep?
Alcohol, yeah. Alcohol, of course, we're not advocating that you use alcohol as a soporific medicine, meaning a medicine to help you sleep. It is probably the most common substance used for insomnia in the world. So if you think about people who drink alcohol just to sleep, it's probably the most commonly used substance, and it should not be. It helps with sleep onset, but when the alcohol level goes down 3 to 4 hours later, then it promotes disturbed sleep. So although it'll help you fall asleep, you'll notice that you're waking up earlier, maybe 3 or 4 hours earlier, and then you have difficulty falling back to sleep. It's like having taken a nap in the middle of the night.
Right. Oh, that's interesting. Okay. And I think we might have time for one more question. Does hydroxyzine have the same long-term effect as Benadryl with long-term use?
I think that short-term use for hydroxyzine is fine. Long-term use, I would not advocate it.
Great. Okay. And Dr. DeOcampo, I know we need to be able to free you up because you've got patients who are going to be waiting for you in a few minutes. So I cannot thank you enough. I'm going to try to show you the group here. Let's see if I can show you the group that you've been talking with. You know, at least you can see them then. So you've got a lot. Can you guys see?
Hi.
We cannot thank you enough for taking your lunchtime with us today. I mean, just a wealth of information. Just so everybody knows, we will upload this, put this on our YouTube channel. Sorry, put this on our YouTube channel. And we will include in that Dr. DeOcampo's contact information. So if you're needing to contact him, you want to have a visit with him, he certainly brings a really unique view. Oops. Sorry. He really brings a really unique view to, thank you, to the picture of Parkinson's disease. So we really can't thank you enough for taking time with us today.
Thank you. It was a pleasure. Yeah, I'd love to be invited again.
Good. We will invite you again.
Okay.
Have a great day. Thank you, everybody who joined us remotely. And we'll see you guys next month for Lunch with Docs, the 4th Wednesday of the month at noon. Thanks, Dr. DeOcampo. Bye-bye.
Bye.